Let's go through the latest papers on aesthetic plastic surgery of the face and eyelids for the month of April. Now, the first paper we're going to discuss is by Elizabeth Kapos, and it deals with validating aesthetic facial surgery results with the FACE-Q questionnaire. Now, this is probably the largest facelift population group in which the FACE-Q has been applied to. The study was performed on 200 facelift patients over the course of 10 years from January 2005 to January 2015. And they conclude that this is an excellent method of clinically validating facelift results and satisfaction rates of patients undergoing facelift surgery. They find out that patients that have had other procedures at the time of their facelift, as well as fat grafting, have higher satisfaction rates. Now, up to date, I believe the landmark paper on FACE-Q for facelift patients was the paper by Sami Sino and Charles Thorne and colleagues from 2015. And of course, the question really is if these questionnaires should be the main basis in which to judge the results of our aesthetic procedures. I think patient satisfaction is the reason why we do what we do, but there are definitely a lot of factors involved in the satisfaction of a patient with his or her procedure. So although it brings in a lot of information regarding whether the procedure we are performing is providing value to our patients or not, of course there have to be other determinants of good results and not only patient satisfaction. It's an important factor, of course, probably the most important one, but of course patient satisfaction may be achieved in different ways, and it would be difficult to compare a specific surgical procedure based exclusively on patient satisfaction questionnaires. The next paper I would like to discuss is by Rémi Foissac and colleagues from Nice, France. They studied how the fat compartments of the forehead change with aging. They studied 100 faces of living Caucasian females and evaluated them over the course of 4.5 years through MRI imaging. They concluded that, contrary to common knowledge that with aging you would lose volume in your fat compartments of the face, they find out that this volume in these areas of the forehead and temporal region actually expand and grow thicker. So they argue that the hollowness that sometimes appears with the aging face is due to other anatomic changes, not to a volume loss. They argue that it might be due to bone or muscle changes. Now they plan to do this study also on the mid-face and even the lower face and neck, so I believe these might provide more knowledge in terms of what's happening while we age. One of the problems of the study, and the authors do recognize it, is that images gathered on the MRI were of course in the supine position. And of course, these are very different than what you might have in the standing position, where you can see more evidently changes due to laxity or to ptosis. This was actually very well brought up, these differences between the supine and the standing position, by a discussion paper, a landmark discussion paper by Val Lambros a few years ago on ASJ. I recommend you read that as well. Nevertheless, a very interesting paper, and I look forward to seeing more of these studies by the authors. And the next paper is authored by Rod Rorick and colleagues, and it's a video plus a paper. It's actually an update of their 2012 paper on the platysmal window and its importance on facial and neck rejuvenation surgery. The key to their procedure is to perform a window in the platysma, caudal and anterior, in order to avoid injury to the great auricular nerve, and then fixing it to the mastoid fascia. I can't agree more with the authors when they state that the cornerstone of facial rejuvenation is a well-defined neck contour. And moving on to ASJ, there are very good papers on aesthetic facial surgery this month, so let's go ahead and start reviewing them. We'll begin by a paper by Tim Wong and colleagues from Australia, and it's a review of the literature on discriminative thresholds for facial asymmetry. Now, this is a must-read paper. It's a really enjoyable read. It reviews the literature on perceptive studies of facial asymmetry. It excludes all cephalometric studies on asymmetry and end up with 7 studies that review the perception of facial asymmetry. They state that there's an increase in detection of asymmetry according to different facial subunits. For example, small asymmetries in the eyelid region of only 2 millimeters are detected, while larger asymmetries of up to 6 millimeters around the chin area are not detected. They also bring up a very interesting concept of left versus right asymmetry, in which they say that an asymmetry of the nose to the left is much more evident than to the right, and contrary to that, an asymmetry of the chin to the right is more evident than those that appear to the left. The authors propose 3 categories of facial asymmetry perception: normal, acceptable, and unacceptable, where there is an intervention threshold. And the authors bring up a very interesting concept that they define as the exponentiality of desire for surgery in facial asymmetry. Very interesting concepts, and definitely a must-read paper, as well as the commentary performed by Farhad Naini, who's a consultant orthodontist in the UK, which actually has a lot of experience in facial asymmetry as well. And why is this important? Well, because patients need to be aware of their asymmetries before surgery, and they need to be informed that probably these asymmetries will not be solved by the surgical procedure. Many patients are not aware of their asymmetries until after the surgery, and normally blame the surgeon for having produced these asymmetries. One of the most interesting papers that brought this concept up was the one from the early 2000s on asymmetries in breast augmentation. I talked about it on my paper on ASJ on asymmetries of the lower eyelid. So I think it is very important to assess with the patient before the procedure the asymmetries that they have, and to let them know that although you will do your best to try to improve these asymmetries and get them to look better, that they will probably have asymmetries after their surgery. And the next paper we're going to discuss, although it's actually on the cosmetic medicine section, it has to do a lot with surgical facial rejuvenation. Now, the paper is performed by Andrew Giacono and colleagues from New York, and they study the use of non-surgical facial rejuvenation procedures in younger patients under 50 prior to undergoing facelift surgery. They evaluated over a course of 10 years all their facelift patients that had their procedure before the age of 50, and came up with 157 patients who were provided with a questionnaire with a 52% response rate. The mean age of surgery was 44 years old, and what the authors found out is that the patients had spent over $7,000 in non-surgical treatments prior to their facelift procedure, starting at the age of 37. They replied that the facelift procedure made them look on average 8 years younger, while injectables made them look 5 years younger and laser treatments 4 years younger. On average, patients had 7 treatments of injectables and 4 treatments of laser prior to undergoing facelift surgery. And they conclude that in general, younger patients that undergo facelift surgery are on average happier than older patients. So they conclude that non-surgical treatments should be a complement to these patients and not a replacement or a way of postponing their procedure. In fact, more than half of the patients stated that if they would have known the result they achieved with their facelift procedure, they would have had it before than when they actually had it. Now, the discussion of this paper is actually performed by the editor of ASJ, Fuad Nahai on his editorial of this month, entitled "The Maintenance Facelift, a Misnomer?" with a question mark. Well, the maintenance facelift is actually a term, I believe, popularized by Tim Martin on his classic clinics paper entitled "The Maintenance Facelift," where he actually sets the basis of performing facelift procedures in younger patients. And what Fuad Nahai really emphasizes is that our patients need to be informed that a facelift procedure, even though performed at a younger age, will not stop the clock, of course. It can provide many advantages around the lower jawline and neck, but certainly perhaps with all these non-surgical procedures, many of these patients that would have received a facelift at a younger age may now see a benefit of these non-surgical procedures around their upper face and mid-face, and leave the surgical procedures probably for changes appearing around the jawline and neck at a younger age. Certainly the editorial this month by Nahai and the paper by Giacono are very much enjoyable papers for the surgeon involved in facial rejuvenation. Now, the next paper I would like to discuss is a fascinating publication by Maria Ray Taban from Beverly Hills, California. He studies the expanding role of orbital decompression in aesthetic surgery, mainly to manage patients with prominent eyes. Now, of course, we all know orbital decompression is the procedure of choice in managing patients with thyroid pathology affecting the orbit. But of course, its indication for purely aesthetic reasons in patients with healthy but prominent eyes has not been studied before. Dr. Taban performs this procedure on 26 patients with prominent eyes but otherwise healthy, and he achieves a 3 millimeter reduction in globe position with no patient experience in diplopia afterwards. And he comments that the key of having no patient experience any kind of diplopia after the surgery depends on two factors. First of all, that the patients are healthy. They have non-fibrotic tissues in the orbit with healthy non-thyroid affected pathology. And the fact that he performs what he calls a graded approach to orbital decompression, in which he first starts off with a lateral orbital wall and intraconal fat removal, and then goes on with a medial wall decompression, and finally with a post-strut removal if necessary. Now, only 2 patients were unsatisfied with their results and considered they had an enophthalmos, so that's a 92% satisfaction rate, which is excellent. And what is true is that 17 out of the 26 patients required ancillary procedures such as fat grafting, cantoplasties to improve their results. Now, the discussion is carried out by Nina Sveger and Dirk Richter from Germany, very experienced surgeons on the use of decompression techniques for orbit thyroid pathology. And they proposed their technique, the Olivari technique, which they published in PRS in 2007 as an alternative to the one proposed by the author. Nevertheless, I think both of the surgeons do mention that this procedure must be performed in expert hands because, of course, the complications can be very important. I believe this is true of any technique. I think that although it may sound very aggressive to do this procedure in a non-reconstructive case, I think all of our aesthetic procedures started out that way. No one would consider doing a nose procedure on a healthy nose, or a facelift procedure on a healthy face, or on a healthy breast, a breast augmentation. But the truth is that any procedure in aesthetic plastic surgery can have devastating consequences for the patient if they are not performed by experienced surgeons that know how to deal with complications or how to perform the procedure adequately. And previously to this technique, the most original procedure was probably the one proposed by Michael Yaremchuk with the use of inferior orbital rim implants, which he published in his paper entitled The Morphologically Prone, regarding the patient with prominent eyes. I think this is a very interesting procedure, which I think may be an important adjunct for any patient wishing to improve his or her appearance, in which there might be a prominent eye deformity. So that's all for aesthetic plastic surgery of the face and eyelids for this month of April, and I hope to see you all next month on Plastic Review. Thank you very much.